Hi everyone. So today we'll be talking about one of the very confusing topic and one of the most commonly asked question during your practicals in Viva. So which device actually gets more medicine into your lungs? Is it nebulizer? Is it DPI? Is it MDI alone? Or is it MDI with spacer? The answer might surprise you. So let's dive into the details. All looking at the device mechanism and requirement. When we talk about nebulizer, they basically convert the liquid medicine into aerosol or mist via compressed air or ultrasonic vibration, depending upon the type of nebulizer you are using. The amount of coordination required by the patient or the inspiratory flow is almost nil. So they are very good in cases where the patient is having exacerbation or patient is severely ill and in children's. Then coming to PMDI, that is pressurized meter dose inhaler, either chlorofluorocarbon or hydrofluoroalkanes. Most of the inhalers nowadays are HFA only because CFC, they are environmentally harmful ozone depleting substances. Their mechanism is the drug and propellant both are released as a fine aerosol on actuation. So the most important thing when you are using PMDI alone is hand breath coordination. Although flow requirement can be low, they deliver fast, they are portable, but they are most error prone when they are used alone. And if they are combined with spacer, the work of the spacer is basically to slow down the velocity of the particle so that the patient gets more time to inhale easily. So there is better deposition into the peripheral airways. Patient coordination is not so much important in this thing. Flow requirement can be low and there is less oropharyngeal deposition, less chances of cold freon effect when you are using spacer along. Coming to the dry powder inhaler. So powder is basically dispersed by patient's inspiratory flow. Patient coordination almost nil. The most important thing with DPI is that they require an inspiratory flow rate of more than 30, around 60 liter per minute. So in elderly patients who don't have a good inspiratory flow, these are not the good choice. They are breath actuated, they require less coordination, but they are humidity sensitive. The real question, how much medicine actually reaches your lungs? And this is the most important question which is asked in your vivas. So, percentage of drug reaching your lungs through nebulizers is 10 to 15%. It is almost similar when you are using a alone PMDI, around 10 to 20%. Slightly increase when you start using a spacer along with 20 to 30%, and DPI remains almost same, that is 15 to 30%. But the oropharyngeal deposition, so when you are using a nebulizer, almost 80% is lost into the environment and tubing. So the efficiency is very low, but it is good, as we told in the previous slide, uncooperative and critical patients. In alone PMDI, again the oropharyngeal deposition is very high, going up to 50 to 80%. But it depends heavily on timing and shaking. And of course, HFA solution, they have a better deposition as compared to CFC. So most of the inhalers which are available in the market are now HFA solution and very rarely you find CFC. When using PMDI with spacer, the oropharyngeal deposition decreases to almost less than 30%, and in DPI it is around 20 to 40%. So here is what I tell my patient, that technique matters more than the device itself. So mostly for most of the asthma and COPD patient who are stable, the best device will be MDI with spacer. Nebulizers mainly for the exacerbation emergencies and infants. And DPI is not to be given if patient is having a low inspiratory flow rate less than 30 liter per minute. So next time someone tells you the nebulizer feels stronger, remember it's mostly the mist you see, not medicine. The MDI with spacer actually delivers nearly double the drug into your lungs quietly and efficiently. Technique beats technology. So, if you found this helpful, hit like, share with your patients or students, and follow Breath Hackers for more bite sized lung science. Thank you.